Good evening, everybody, and welcome all of you to this live program at Orthopedic Principles. Today, our guest of honor is Professor Abhijeet Wahegaonkar from Pune, India. Dr. Wahegaonkar is a fellowship-trained orthopedic upper extremity, hand, and microvascular reconstructive surgeon with more than 18 years of exclusive experience in management of upper extremity problems with a strong emphasis on academics and research. After completing his residency in orthopedic surgery, he received higher surgical training in hand surgery, microvascular surgery, brachial plexus, and peripheral nerve surgery in various prestigious institutes across the world, which includes a fellowship at the Kleiner Hand Surgery Clinic, and also as a research fellow at the Mayo Clinic in the United States for a period of 2 years. Dr. Wahegaonkar has also earned a master's degree in clinical and translational services and sciences from the Mayo Clinic. Dr. Wahegaonkar currently serves as the secretary of the Pune Orthopedic Society. If you've noticed, Dr. Wahegaonkar has delivered a couple of lectures on a channel which have reached to a huge audience. And today it's my great honor to bring back Dr. Abhijeet Wahegaonkar for this wonderful live program. Over to you, Abhijeet.
Thank you very much for that generous introduction, Hitesh, and it's an honor to be back sharing thoughts and sharing some insights on Kienbock's disease. I'm very grateful to you and to the Orthopedic Principles and all those who are finding time from their busy practices and amidst the pandemic that has challenged us all to continue education and continue excelling in our clinical field. And I hope everyone out there is safe, whoever and wherever you're watching. And I wish you all the very best. And I hope that everyone is safe and healthy. So without further ado, my topic for tonight is to speak on Kienbock's disease, which is a very common clinical problem that we come across and which continues to pose a challenge, because there are several treatment options and decision making can sometimes be a challenge. So let us try and make it a simple or a simplistic endeavor and enable us to treat our patients in a very optimal way. So with that brief introduction to the topic, let us now understand a little bit more in detail about Kienbock's disease. So Kienbock's disease is named after Robert Kienbock, who was a radiologist, and in 1910 he described this condition, and it is a condition that essentially is an avascular necrosis or a lunatomalacia which progresses if left untreated and causes carpal collapse, and this in turn changes the kinematics, the kinetics and the biomechanics of the wrist joint and results in secondary arthritis of the wrist joint. And the etiology, although in a majority of cases remains to be elucidated, there are several theories that have been proposed. And one of them is a microfracture theory, another is a ligament injury or injury to the vessels within the ligaments, or it may be attributed at times to a negative ulnar variance. However, at the end of the day, we all need to appreciate and understand that it is a multifactorial pathogenesis rather than a single etiology that will result in Kienbock's disease. And this may be influenced by genetic, anatomic, mechanical, and metabolic factors. So Kienbock's disease, even before Robert Kienbock, this slide here on the right-hand side of your screen is that of Robert Kienbock. But way back in 1843, Peste described this, although he did not have radiology at that time, because Röntgen was yet to come into the picture with his x-rays. So he discovered that the lunate was fractured and collapsed in some anatomic dissections in cadavers. However, it was not until 1910 that Robert Kienbock used x-rays to describe the radiological appearance and the clinical symptoms, and therefore we now know this particular problem as Kienbock's disease. And I'm sure very many of you would have seen this clinical picture and the radiological picture where the shape of the lunate has changed. You can see it is sclerotic. There is a negative ulnar variance as compared to the radius. There is a carpal collapse. Essentially, the lunate is trying to push its way down after the lunate collapses, and then you have the diagnosis of Kienbock's disease. So coming back to the etiology, and we just talked about the ulnar variance, the normal variance of the ulna is that of neutral. However, if the ulna is longer than the radius, we call it as a positive ulnar variance. When it is shorter than the radius, it is called as a negative ulnar variance. And then we need to recognize that a positive ulnar variance, so if you have the radius just like so, and the ulna is positive, it would cause an ulnocarpal impingement or an impaction and not Kienbock disease. A lot of times you would still see some signal change in the lunate on a T2 sequence, which should not be confused with Kienbock's disease. So in Kienbock's disease, the ulna is negative variance, and it is thought then there are increased forces in the radiocarpal joint in the lunate fossa, and that leads to Kienbock's disease. Then we also have the vascularity of the lunate that may play a very important role in resulting in Kienbock disease. And there have been very wonderful studies by Dr. Richard Gelberman, where he did these injected and decalcified studies of the bones and looked at the vascularity of the carpal bones. And then they found that the vasculature in the lunate, so if you have the lunate in the lateral view, just like so, you either have a Y-shaped or an X-shaped or just a transverse kind of pedicle that goes across the lunate. And if you have any fracture, that may lead to Kienbock's disease, especially when there is only one single pedicle across the lunate. We also need to take into consideration the lunate geometry. And then there is a classification by Dr. Stephen Vegas, where he looked at the morphology of the lunate or the geometry of the lunate, and he divided them into type 1 and a type 2. And if you have a facet for the hamate, and this is called as a type 2, that is when there is an increased predisposition for developing avascular necrosis or Kienbock disease in such lunate morphology. And then, of course, we have the most plausible theory, that of a mechanical injury, the nutcracker effect. When the wrist goes into hyperextension, the lunate gets crushed between the capitate and the distal articular surface of the radius. There may be a microfracture, and that may result in Kienbock's disease. So with that background into the possibility or the etiology of Kienbock's, a patient who comes to you with a wrist pain, a reduced grip strength, reduced range of movement, especially that of flexion and then some in extension, with normal supination and pronation, you should almost always entertain a differential diagnosis of Kienbock's disease. And many times, they may also have a carpal tunnel syndrome, which needs to be diagnosed and kept in mind. And then when you have a patient who, where you suspect Kienbock's disease, obviously you would want to investigate these patients. And the first order of the day is to get radiographs. And the radiographs should be in what we call as a neutral view of the wrist joint. What is meant by a neutral view? The elbow is at 90 degrees with the shoulder at 90 degrees abduction, abduction, the elbow in 90 degrees of flexion, and the wrist is kept in neutral. So the patient has often got to sit at a lower level than the X-ray table to achieve that position. And in that position, you would take a posterior-anterior view. And then you take a lateral view, and then you take an oblique view. So when you have a neutral PA view or a posterior-anterior view, you would then look at the X-ray and look at certain important parameters and findings, which would include the ulnar variance. You would look at the shape of the lunate. In the normal posterior anterior view, the lunate would appear quadrangular. However, when it appears sclerotic, when it appears fragmented, cystic, and triangular, there's something going on with the lunate. You would also like to confirm the Young's index, or the carpal height ratio, which is the height of the carpus divided by the height of the third metacarpal, and the Young's index normally is 0.53 plus or minus 0.05, and when that is altered, you would then infer that there is a carpal collapse. Essentially, that means because the lunate has collapsed, the capitate is trying to push its way down, and that is what causes a change in the Young's index, or the carpal height ratio. Later changes on the X-ray would include fracture of the lunate, increased density, collapse, a DC pattern on the lateral view. There will be a flexion of the scaphoid leading to the ring sign. You may also see a scapholunate dissociation, and then depending upon the stage of the disease, you would have arthritic changes. Other investigations would include a bone scan, but this is a non-specific kind of an investigation, and it does not rule out early avascular necrosis, and today it is pretty much redundant. But this is just for the sake of completion and interest that I included that particular slide. You also could get a tri-spiral tomography, which is more accurate than X-rays alone for staging. However, again, it does not rule out early avascular necrosis. In this particular view, you would appreciate that there is a fissure here, there is something going on here, and a fragmentation here. So you can see that the tri-spiral tomography is a very accurate way of looking at the lunate fractures. Then the CT scan is perhaps one of the more preferred investigation, which provides useful detail of fracture fragments, and that would help you in determining your procedure. And here in this slide, for example, you could see fragmentation of the lunate with collapse of the capitate. There are some cystic changes in the capitate as well that indicates an advanced arthritic change in the wrist joint. In Kienbock's disease, MRIs are of great importance because they're sensitive and specific, and they correlate pretty well with the histology. And the low T1 and T2 signal with an abnormal signal involving more than 50% of the lunate usually clinches the diagnosis of Kienbock disease. And it is a very important adjunct to your clinical examination and suspicion of Kienbock's disease. Now, let us move on to the staging of Kienbock disease, because this is going to help you in planning your surgical treatment or your line of management. Let me not say surgical treatment, but the line of management for your patients. So the most common classification that I'm sure all of you must be familiar with is the Lichtman classification, which was a modification of the Stell's classification. And Lichtman talks about stage 1 to 4 with increasing severity of the arthritic changes. So you have stage 1, 2, 3A, 3B, and stage 4. And I won't belabor too much on those stages because I'm sure all of you must be familiar with this. And then Peter Amadio from the Mayo Clinic added another stage, which is stage 0, where there's a normal X-ray and an abnormal MRI, which is a very early stage. And for example, in this particular X-ray, everything looks fine, nothing looks amiss. However, the MRI shows early changes in the lunate, and that is stage 0. So stage 1 very quickly is where the X-ray is normal or there is a linear lunate fracture, and the diagnosis is usually by an MRI, a bone scan, or tomograms. And that is usually the very early stage of Kienbock's disease. Stage 2 is where you start seeing changes in the density of the lunate. So the lunate starts appearing sclerotic. There is a small loss in height on the radial side alone, and that is stage 2. Stage 3A is where there is further lunate collapse. I'm sorry, this is a typo. This should be a PA X-ray or a posterior anterior view. So the PA X-ray is where you start seeing the lunate change its shape from quadrangular to triangular. That indicates that there is a DC deformity. The lunate is in extension, and the lateral X-ray will then show there is an elongated new lunate, and there may or may not be DC, and there is no scapholunate dissociation. And this is how a stage 3A would look like. Stage 3B is again a further extension of the disease where the lunate is collapsed. There is a fixed rotation of the scaphoid giving rise to the so-called ring sign, which indicates scapholunate dissociation, and there is a static carpal collapse. Stage 4 is when there are arthritic changes in the wrist joint because of Kienbock's disease. So this is a summary of the classification wherein you have the stages 1 to 4, and then you have the findings based upon whether you're getting X-ray, CT scan, MRI. And the most recent addition is that of arthroscopy. And Greg Bain has added so much to our understanding of Kienbock's based on arthroscopic findings, and we'll briefly review that classification in a short while. So the treatment of surgical disease, of Kienbock's disease, is either non-operative or operative. And a lot of times non-operative treatment may not be effective, and that is when surgical treatment may be indicated. And surgical treatment can be broadly classified into mechanical, biological, and salvage procedures, of which the biological procedures are perhaps of greatest interest because you're trying to revascularize the lunate by performing vascularized bone grafts. Very quickly, the mechanical procedures would involve joint leveling procedures, wedge osteotomies, intercarpal fusion, and capitate shortening osteotomy, which is called as a Grainer procedure. And essentially, the mechanical procedures aim at redistributing the forces acting across the radiocarpal joint in an attempt to treat the avascular necrosis and collapse of the lunate. So joint leveling procedures, wedge osteotomies, intercarpal fusions, and capitate shortening osteotomies. Salvage procedures are for more advanced disease where arthritic changes have already been established, and they usually involve excision of the lunate and then either proximal row carpectomy or limited or partial wrist fusions. And lunate prosthesis was also described, but it did not meet with success and is now no longer performed. But proximal row carpectomy and lunate excision with or without intercarpal fusion perhaps remain the most commonly performed procedures for the treatment of Kienbock disease, especially in stage 3A and 3B. However, when there is panarthritis of the wrist joint, total wrist arthrodesis is perhaps a good option for dealing with the problem. Biological procedures include revascularization of the lunate, and these are usually performed by using a perical vascularized bone graft, which is borrowed from the dorsal aspect of the radius based on something called as the supraretinacular arteries, which are in relation to the extensor compartments. And the most commonly used for the lunate is the 4-5 intercompartmental ICSRA, intercompartmental supraretinacular artery. So the bone is harvested along with the pedicle, which is extended to the artery, the 4-5 ICSRA, and that is then flipped into the dorsal aspect of the lunate. These bone grafts can also be harvested from the volar aspect, and Kuhlmann had described the bone graft based on the pronator quadratus pedicle. PC form based on its pedicle was described by Philippe Safar from France. And this is usually a little difficult kind of a technique because of the extensive approach that is required. And hence, the dorsal bone graft is perhaps more popular when you're looking at a biological option for dealing with Kienbock disease. Vascularized bone grafting has had a long history, and pronator quadratus pedicle bone graft was performed very commonly. However, the results were variable with about 50% success rate, whereas the vascularized PC-form bone graft was a better option in the hands of Philippe Safar. However, this is not an easy procedure, but it is regaining interest now. We also have described a procedure wherein we use the volar approach. This is an extension of the work of Kuhlmann. And this is a slide from my friend, Professor Max Herrle from Germany, thanks to him. And in this cadaver specimen, you can see that we can harvest a bone graft from the volar aspect of the radius, just distal to the pronator quadratus. There is a consistent artery, the transverse carpal branch, that is given off. And this bone graft can be harvested based on this pedicle and then flipped into the lunate on the volar aspect. And at the same time, we can perform a closing wedge or a shortening osteotomy of the radius, and thereby provide a biological as well as a mechanical modality of treating Kienbock disease. So this is how the incision is taken. It is an extensive approach on the volar aspect of the wrist and the forearm. And then you look for the radial artery, and this is the transverse carpal branch, which is given off. You identify the branch just distal to the pronator quadratus, and you harvest that artery along with a cuff of adipofascial tissue, and then you harvest the bone graft from the medial and volar corner of the radius, and then you flip the bone graft into a trough in the lunate and fix it with either a K-wire, or you just stuff it into the lunate. At the same time, you can perform a closing wedge osteotomy of the radius like you see here, and you can fix it with a plate to shorten the radius and do a mechanical decompression of the radiocarpal joint. And here is a case example wherein you can see that the lunate is avascular. The arthroscopic view shows lunatomalacia. However, the cartilage is intact, but it is softened. And once you have done a shortening osteotomy and a pedicle vascularized bone graft, the lunate has arrested its progression, and you can see some revascularization of the lunate on a post-operative follow-up. So another modality of vascularized bone graft is to use PC-form pedicle bone graft, and however, this has got variable results again, and we find the dorsal vascularized bone graft to be a more reliable and a robust procedure. So the dorsal vascularized bone grafting was popularized by the Mayo Group, and the dorsal vasculature of the radius and the carpus was studied in great detail in animal and cadaver studies, and they found a very consistent artery that comes off in the first and the second intercompartmental and the fourth and the fifth intercompartmental recess. And this is a retrograde flow vascularized bone graft. And this is how the bone graft is harvested with a very nice long pedicle. And this is flipped and is inserted into a core that is created in the lunate, thereby vascularizing the lunate. So this is a very robust kind of a technique, and gives very consistent outcomes in Kienbock disease. So there are several studies that have been performed in various institutions proving the reliability and reproducibility of this particular technique. So what are the determinants of Kienbock's disease? First and foremost, it is a stage in which the patient presents to you. You look at the ulnar variance, and then of course you take into consideration the patient's occupation, you take into consideration the dominance of the hand, the age, the socioeconomical factors, and so on and so forth. There are other modalities of treatment that have been described with varying success, such as core decompression of the radius, capitohamate arthrodesis, shortening of the capitate, and there are several procedures that have been described, even including lunate excision and lengthening of the capitate, which is a Grainer procedure. And all of these procedures have had variable outcomes, and they are short retrospective studies. So we don't have a prospective randomized clinical trial to prove the efficacy of one procedure over the other. Salvage options we have already talked about, but just to revise, there is lunate excision with proximal rocapectomy or a partial wrist fusion. Denervation of the wrist is also one of the options, and total wrist arthrodesis is reserved for advanced arthritis or unsuccessful previous surgery or complications of other surgeries. So the capitate advancement, just to kind of highlight the procedure, this is where the lunate is excised, the capitate is osteotomized and is lengthened with the bone graft, so that the capitate head now occupies the place of the lunate. So again, this is something which is successful in very few hands. Grainer described in 1966, wherein he showed 18 patients with 22 months follow-up and all with satisfactory results. However, this outcome is not consistent in different institutes and different centers. Proximal rocapectomy perhaps remains one of the most commonly performed procedures for Kienbock's disease, and it usually provides very good outcomes with useful functional range of movement and grip strength. And it is something that gives consistent results, as proved by the studies of Peter Stern, where they looked at outcomes of long-term outcomes of proximal rocapectomy and partial wrist fusion. And if at all there is a failure of this procedure, you could convert it to a total wrist arthrodesis or an interposition arthroplasty. Denervation of the wrist joint is also one of the options to control the pain. However, this is indicated when there is reasonable movement, and you would do a denervation of the wrist joint by performing a nervectomy of the articular branches arising from the radial nerve, the ulnar nerve, the posterior interosseous nerve, as well as the anterior interosseous nerve. And the outcome again is variable, and this usually will progress to arthritis, and then something more definitive needs to be done. So when we talk about treatment for Kienbock's disease, what are the algorithms that prove to be consistently useful? And this is where the Begg and Bain classification based on arthroscopic finding comes in. And they describe Kienbock's disease in four stages: stage 0, 1, 2A, 2B, 3, and 4. And what are these stages? So grade 0 is where there is zero non-functional surface. Essentially what it means is that all the articular surface look good, and these conditions are best treated by either a joint leveling procedure, a forage with or without bone graft, or a vascularized bone graft. Grade 1 is where there is only one non-functional surface, and that is usually the proximal lunate. So the proximal lunate articular surface, when it is involved, you would perform a radioscapal lunate fusion, a proximal rocapectomy, or an osteochondral grafting of the lunate. Grade 2A is when there are two non-functional surfaces, and these involve the distal articular surface of the radius and the proximal lunate. And when you have this condition, you would perform a partial wrist arthrodesis in the form of radioscapholunate fusion. Grade 2B is when there are two non-functional surfaces, and these are of the proximal and distal lunate, which means essentially there is a fragmentation or a fracture of the lunate involving the mid-carpal aspect of the lunate as well as the radiocarpal aspect of the lunate. And these cases are best treated by either a proximal row carpectomy, a lunate replacement, again, this is something which is not performed, and then a capitate lengthening if at all. Grade 3 is where you have three non-functional surfaces involving the mid-carpal aspect of the lunate, the radiocarpal aspect of the lunate, as well as the distal articular surface of the lunate fossa. And these are again treated either by scaphocapitate fusion or a hemiarthroplasty. Grade 4 is when all articular surfaces are non-functional, and these are best treated by a wrist fusion, a total wrist arthroplasty, or a scaphocapitate fusion if the radial column is intact. But mind you that in all cases, synovectomy is performed, and that adds to the benefit of the outcomes. So with all of that in mind, let me just share with you how I plan my treatment. And essentially, I perform an arthroscopy in almost all patients with Kienbock disease. And if the lunate is salvageable with the cartilage cell intact, or if there is a simple coronal fracture, and if it is not salvageable with a fracture with separation and cartilage shell is fragmented with multiple tears. If there is a salvageable lunate, the goals are to revascularize and to get the lunate to heal. And this can be accomplished by a vascularized bone graft or an AV bundle, such as a procedure of HORI, or you can perform an unloading procedure, and that there are several options to it, and you may use what works best for you, or an open reduction internal fixation of the lunate if there is a coronal fracture. If there is an unsalvageable lunate, the goal is to relieve the pain, preserve the motion, and this can be done with a partial wrist fusion, a proximal row carpectomy, and that usually gives you good outcomes. More and more, we are resolving to arthroscopy, which gives you a chance to peep into the joint. You can stage the disease and then even perform your partial wrist arthrodesis or even proximal row carpectomy in a minimally invasive manner, and thereby preserving the biology and the soft tissues and the vascularity, and thereby improving the fusion rates. Here, I'm performing a scaphocapitate fusion after the lunate has been excised. This is the mid-carpal joint, and this is the scaphoid, and this is the capitate. Let me show you this video again so that you orient yourself. Let's go back. And so I'm removing the articular surface from the capitate and the scaphoid in order to go to the subchondral bone and thereby perform a percutaneous fusion of the scaphocapitate articulation and perform a partial wrist arthrodesis. So you can see here I'm removing the cartilage of the scaphoid, whereas the capitate has already been dealt with. And then we use either a Herbert screw and a K-wire, and we look at the range of movement on table. This is performed percutaneously and kind of gives you a minimally invasive manner of dealing with Kienbock's disease. Other options include wrist arthrodesis, and this is primary treatment when the patient requests because of socioeconomic or occupational factors. It is often the final solution for failed salvage procedures or patients who present to you with very advanced panarthritis of the wrist joint. Denervation, again, is an adjunct to other treatments, but is not a very robust procedure for Kienbock's. So in summary, the treatment of Kienbock disease is more often than not a combination of a mechanical procedure with a vascularized bone grafting or a biological procedure. The mechanical options are aimed at unloading or replacing the lunate. The biological procedures are devised to revascularize the lunate, whereas the salvage procedures are aiming at dealing with arthritic changes, and they usually involve arthrodesis in some form or the other. So with that, I thank you for your attention, and I'll be happy to take any questions that anyone might have. Thank you very much.
Thank you, Abhijeet, for yet another fantastic lecture.
Thank you.
Just questions from our side. Suppose you're able to pick a Kienbock in the very early stage. For example, there are changes on MR, but not on the X-ray. So how do you go about? Do you go about with a core decompression and a STT pinning or kind of offloading procedure?
Right. So there are very many ways to skin a cat, and the very fact that there are so many options that are available for the treatment of Kienbock, speaks volumes that none of them is perhaps the most effective way of dealing with it. And we yet do not have conclusive evidence as to what works best, and especially when this is a very early presentation like you just mentioned. And there are several modalities of treatment, and right from core decompression to getting an AV pedicle and implanting it into the lunate, to even just applying a temporary external fixator to offload. People have even used splints to immobilize and performed shortening procedures. So to be very honest, this is not a very easy answer. But in my books, I would like to spend time with the patient. A lot of times, even with stage 2 and stage 3 and stage 3B, patients may still have reasonably good outcomes, range of movement and function. And it is very surprising to see that the X-ray and the MRI may look alarming, but the function is pretty good. So you need to connect with your patient and not treat the radiographs and the MRIs and the CT scans. You need to first examine your patient, understand his requirements, especially in terms of his profession, hand dominance, and his socioeconomic status, more so in our country. And then you need to discuss all his treatment outcomes or options with him, and then help him make informed decisions. So a lot of times we see, to our chagrin, our residents and fellows jumping at a treatment option just by looking at the MRI or the X-ray, which is not a good practice. You need to understand the patient's requirements, which is of paramount importance, and then set a foot into the realm of treatment. And then there are multiple procedures that you can pick, and based on what stage the patient is in, and then you can go about dealing with it. And remember that most of the times, whatever you're doing, you're buying time, and there is always a possibility of the patient coming back with an advanced stage, or say, for example, you perform a proximal rocarpectomy today, a few years down the line, he may require a wrist arthrodesis should the arthritis progress. Or if you performed a partial wrist fusion, he may still progress to arthritic changes at a later date. You need to counsel your patient regarding this aspect of Kienbock disease. So,
and because the condition is not that common, isn't it? That's
yes.
why we have this problem of getting the right treatment. Because when the disease itself is rare, you're going to have problems.
Exactly. The disease is rare. There are stages in it. There are different classifications. There are so many procedures, and that's the reason why we do not have compelling evidence about what works best. And hence, I'm sure, someone from the audience may come up with a new treatment option for Kienbock if you really focus your studies in the treatment of Kienbock disease.
And what has been your personal experience? Like how many cases you have seen, and what were the common procedures that you've done for it?
Yeah. So as a hand surgeon and as a person who's working in a tertiary referral center, we end up seeing quite a bit of Kienbock disease. And just to put things in perspective, we end up seeing at least 2 to 3 patients of Kienbock's in a regular week. Sometimes we may go without seeing them, but on average, I think we see at least about anywhere between 5 to 10 cases a month. And let me, choose my words with caution when I'm talking today, is that we do not, jump to a surgical option for our patients at the get-go. We first counsel, of course, and that is based on, what stage the patient is in. And like I said, even in an advanced stage, the patient may have reasonably good function with occasional pain. And if the patient is not all that, is not all that compromised in the function, you may still want to splint him. You may still want to, utilize non-operative modalities of treatment. And we usually let the patient ask for surgery if the problem progresses or if the patient finds it fit for a surgical intervention.
And just for the sake of residents, I think the Stahl and Lichtman classification is still one of the most common, right? Because the other one is slightly more advanced for a surgeon's perspective, one who does a wrist arthroscopy, isn't it?
Yes, that is right. And I think the Stahl and Lichtman classification, or Lichtman's classification, or Stahl's modification of Stahl's classification, is perhaps the most universally accepted treatment classification. But there is a recent publication by Bain and Lichtman where they come up with a new textbook of Kienbock's, and that's where they refer to the Beg and Bain classification. So people who are performing wrist arthroscopy, they would perhaps lean towards using the Beg and Bain classification, which kind of is a more comprehensive classification, which gives you the options for treating these patients based on the classification. So,
just one last question before we wind up, Abhijeet.
Sure.
You mentioned about wrist fusions, right? So for a resident, because there are a lot of residents online, and can you explain that tri-scaph fusion versus a four-corner fusion with respect to box?
Yeah, very good question. So it would be a three-corner fusion because we excise the lunate, and we would do either a scaphocapitate fusion. So it's a two-corner rather, not even a three-corner, two-corner fusion. However, the tri-scap fusion has fallen out of favor because of several reasons. So when we talk about tri-scap, we're talking about the scaphoid, the trapezium, and the trapezoid. So essentially, there are the distal articular surface of the scaphoid, the trapezium, and the trapezoid, and the intertrapezio-trapezoid surfaces. So there are multiple articulations that need to fuse, and if there is a fibrous non-union, that can be a painful outcome for the patient. So it is not an easy arthrodesis to perform. 1. 2 is that it creates a very rigid radial column. You can imagine the scaphoid, the trapezium, and the trapezoid all in one fusion mass. So it creates a very stiff radial column, and the radial and the ulnar deviation, as well as the flexion and extension, are compromised. Now, because you're saying that there are a lot of residents and fellows who are watching this webinar, let me very quickly elaborate a particular point. Why is it that we perform a partial wrist fusion, or why is it that we perform a proximal row carpectomy? For this, we need to understand the basics of the wrist kinematics and kinetics. The proximal carpal row of the wrist joint is an intercalated segment. What that essentially means is that it is a segment where there is no direct tendinous insertion, and hence the movements of the proximal carpal row with the ligaments intact, the scapholunate and the lunotriquetral ligament intact, are imposed upon it by the distal carpal row and the articular surface of the radius. So when the wrist extends, the proximal carpal row extends. When the wrist flexes, the proximal carpal row will flex. When there is radial deviation, the proximal carpal row will extend. And when there is, will flex. And when there is ulnar deviation, the proximal carpal row extends. Now, when there is a scapholunate ligament injury or a lunotriquetral ligament injury, or you're excising the scaphoid, or you're excising the lunate, you cannot leave the carpal bones just like that, because there is going to be compensatory rotation of the remaining bones, thereby altering the wrist biomechanics. For example, if you excise only the lunate, the scaphoid is going to flex, and that's going to cause a problem. Or if there is a scaphoid non-union, you're doing a salvage procedure, you excise the scaphoid, the lunate is going to extend with the triquetrum, again a problem. So to neutralize these abnormal positions, you need to do something about the remaining proximal carpal row bones. So to prevent the scaphoid from flexing, in this case, in Kienbock's disease, for example, you remove the lunate, the scaphoid is going to flex. So maintain the scaphoid in extension. You could do either a tri-scape arthrodesis, just like you said, or a better alternative is to fuse it to the capitate. And in doing so, you have a larger articular surface. You don't have to deal with multiple articular surfaces, and you can get good compression across the articular surfaces in a robust manner, and then it's a more reliable procedure. Or you could excise the lunate, you could excise the scaphoid, you could excise the triquetrum, which is called as a proximal row carpectomy, and that would again convert a hinge, a link joint into a simple hinge joint. The capitate will come down and sit in the lunate fossa, and then you would just have a good movement in the wrist joint. So that's just the basics of why we perform either a fusion or a proximal row carpectomy when we are dealing with Kienbock's or scaphoid non-unions. I hope that helps.
Great. Thank you so much.
Thank you.
I think that's all the questions that we have for this session. Abhijeet, fantastic lecture. I'm sure this is going to beat the other one and go to a much bigger audience all over the world. Thank you so much for joining.
Thank you very much. It's always a pleasure to be of help and use in advancing knowledge in science. Thank you so much.
Bye-bye.